Um, Let me start again with an acknowledgement that I'm drinking coffee. Our research currently is funded by the NIH, the AHA, and the U.S. Hybrid Blueberry Council. None are related to this. And I served as principal investigator of a previous NIH project that itself received support from industry contributions separately to the Foundation for NIH. Um, no other conflicts to disclose related to this. 2025 was, it's convenient that we're doing this in early 2026 because 2025 was a busy year for alcohol, as it were, and health. So I think it's a great opportunity now to take a fresh look at these questions. In part because there's been just an enormous amount of misunderstanding and misinformation related to this over the course of the last year. Now, under other circumstances, I might take a poll to ask how many of you heard of or read the Surgeon General Advisory on Alcohol and Cancer Risk, which you see on the left. I suspect that's a decent number of you. I might separately ask how many of you read or heard of the National Academies of Science, Engineering, and Medicine Review of Evidence on Alcohol and Health, which came out almost the same day last year, and which I suspect very few of you read. Despite the fact that the latter is something like about 100 times longer than the former. In part because although these came to very consonant but not identical conclusions, I think we've been left in this sort of position where it's hard to understand kind of exactly where we are on this topic. So I'm going to try to give you in the next 45 minutes or so a sense for where the research stands. And as you'll hear, I'm going to take a particular eye to this, in part related to sort of our background dealing with alcohol, and in part related to what we know from gold standard studies. So let me start with a background about ethanol itself. Ethanol is the specific alcohol in what we call alcoholic beverages. The evolutionary picture that surrounds that, and some recent trends in drinking to sort of set the stage. We'll sequentially after that talk about some evidence from randomized trials, the effects that we seem to see in epidemiological studies, what we don't have yet, and perhaps what we need, and then finally some recommendations. So this is an ethanol molecule, 2 carbons. It is a macronutrient like sugar, protein, and fat, although not an essential one, and produces 7 kilocalories per gram. So if we drink alcohol, we're getting calories from it. It is produced in nature from the fermentation of sugars by yeast. This occurs everywhere, as we'll see. Humans have managed to tame this, as it were, in a couple of ways. First, by identifying yeast that are particularly good at this fermentation. But secondly, then by concentrating that by distillation. Fermentation will, at its maximum, lead to a concentration of alcohol in a beverage of about what we see with wine. So that's going to be about 15% maximum. Quite a bit less in nature in most circumstances, and everything above that is created by humans. So here's the metabolism of ethanol, and it's worth going through this just a bit because it tells us a lot about what alcohol does. So ethanol is converted to acetaldehyde by a series of enzymes. We have actually a lot of these called alcohol dehydrogenases, or ADH. Acetaldehyde is then immediately and rapidly converted and fully converted from acetaldehyde to acetate. Acetate is vinegar, and so this can enter the Krebs cycle. Every cell in our bodies is capable of using this for energy. This process is mediated by aldehyde dehydrogenase enzymes. Those we also have essentially in every cell in our body. 90% of this first stage occurs in the liver, where it's rate limiting. So the slowest process is going from this to this. And then, as I said, this is quite rapid. This stuff in the middle, acetaldehyde, is aversive. It is mutagenic. That is, it injures DNA, which ethanol by itself does not. So much of what we know about the harms of alcohol and drinking too much alcohol relate to buildup of this acetaldehyde, which in a substantial number of people, particularly of East Asian descent, may not be easily converted to acetate if they don't have high activity of their aldehyde dehydrogenase enzymes. Now, it's important to note that this first step can be overwhelmed. So it works at very low concentrations. Essentially, with the first sip of alcohol, we'll be converting it to acetaldehyde and then on to acetate. But at high concentrations, it can be overwhelmed. And then other enzymatic processes are brought into play, which is to say that we might not expect the same effects of alcohol at low dose and high dose simply because we're not using the same enzymes to metabolize it. So as we're going to see, there's good reason to suspect that the process isn't always linear simply because the metabolism itself isn't linear. Now, primates have been exposed to ethanol for a very, very long time. This is a Malaysian pintail tree shrew. This is perhaps the oldest direct descendant that we have of our original primate ancestors. And this little fellow goes out every night and drinks something called Bertam palm nectar. So he's looking for nectar inside palms. And it turns out that if you look at the nectar that he's getting, if he sips the outside nectar outside of the bud, that has a small amount of alcohol in it, but as he gets a deeper and deeper into the bud, it has more and more natural alcohol, up to, you can see, about 1% by volume. So this is not even the equivalent of beer, but nonetheless, if you're this size, this eventually turns into quite a reasonable amount of ethanol. And so every night he's going out, and with his food, he's having a small amount of ethanol. I want to come back to that. In addition, following evolution of this little fellow, another mutation occurred about 10 million years ago. We'll get back to this in just a moment, that endowed our ancestors with an enhanced ability to metabolize ethanol, which is to say that we currently metabolize it more effectively than this little fellow does. And interestingly, that occurred virtually simultaneously in evolutionary terms with when primates left a purely arboreal existence and adopted a terrestrial existence. So at least hypothetically, there appears to have been selective pressure to metabolize ethanol because we were exposed to more of it in the course of our day-to-day lives, searching for food. Now, it turns out that little fellows like that one not only drink the ethanol every night, but they prefer it. So in controlled experiments, and these are controlled experiments in two different early primate species, the II and the slow loris, both of which are arboreal and both of which are nocturnal. When offered the choice between foodstuffs that have lower or higher ethanol, they both will consistently prefer the higher ethanol beverages, higher ethanol foods. So they will eat lower ethanol ones, but would prefer, when given equal choice, higher ethanol ones. So it's not just that we encounter it, there seems to have developed a preference for it, almost certainly because, as noted, the fruits that have the most ethanol, by definition, had the most sugar in them to start. Now, it turns out that, as I said, this has continued beyond just those early primate species. These are chimpanzees, on the top a pair of males, on the bottom a pair of females, both of which are eating breadfruit. And much the same way that you saw with the palm nectar, as breadfruit ripens in nature, it will become somewhat, not demonstrably, but somewhat, not markedly, but somewhat alcoholic. So that we're getting somewhere around 0.3% alcohol by volume within this breadfruit. Now, that may not sound like much, but these breadfruit can be 100 pounds or more. for a single fruit. So this effectively turns into a large amount of ethanol. And so not only did our ancient ancestors do so, but even now chimpanzees will actively seek out ethanolic beverages, but again, only in low quantities and with their meals. We'll get back to that. Now that's what other primates do. What do humans do? So this is data from Gallup on the use of alcoholic beverages in America. They've been asking essentially the exact same question since 1940. You can see that the question might not use the terminology we would otherwise not have used, but it was common in 1940. And so I'll point out a few things here. First of all, you can see that alcohol consumption peaked at about 1980. That was the only time that over 70% of adult Americans reported using alcoholic beverages. And then you can see that it went down fairly steadily down to about 1990. And then it's been, more or less constant since. Now, in the most recent one, in 2025, there was a drop. We don't know whether or not that's going to persist or not. It'll be interesting to see what happens next year. But this gives you some sense for how use of alcoholic beverages in America has been changing over time. However, this disguises some perhaps more durable patterns that we're seeing. And so this uses a slightly different metric. This is looking at gallons of ethanol consumed per capita in America based on usage. But divided by beer in green, spirits in orange, and wine in purple. And so you can see beer consumption since that peak in 1980 has been steadily declining. In contrast, spirits declined markedly from 1980 to 1990. So that really reflects what you just saw in the last slide, but has been creeping back up. And actually, interestingly, A is now similar to where it was in 1980 and actually slightly higher than beer. And lastly, wine has been sort of shifting up and down, but because its overall use is much less than the other two, accounts for much less total ethanol consumption. And so we have this sort of interesting pattern where we essentially much of what we've seen has been a decline in overall consumption, but also with a replacement of beer with spirits. And when you're talking about the use of alcohol in America, it's very important to understand at least two other things about it. First of all, it's very age dependent. And so this is just the percentage of individuals who report using any alcohol in the last month. You can see, not surprisingly, that it jumps up and peaks amongst young adults, and then essentially steadily declines through the lifespan. But another important thing to note is that much of the alcoholic beverage consumption in America is not what we would consider safe. So in these bars, the purple indicates individuals who are consuming alcohol, what I'll call safely here, which simply means that they do not binge drink. And binge drinking, by this definition, is 5 or more drinks in a day for a man or 4 or more drinks in a day for a woman. And so you can see that until about age 50, as many adults report drinking with binges as without. And it's only after about age 50 that we begin to see a shift such that most of the drinking is not accompanied with binges. Now, given that, I want to separate, because we're not going to talk a lot more about this, what I consider the clear set of effects of heavy alcohol consumption. These are things that are unequivocal, that we know a lot about. And so heavy drinking, and I'll talk a little bit more about what I mean in that regard, has been strongly linked with cardiomyopathy, stroke, high blood pressure, liver cirrhosis, pancreatitis, even a specific form of dementia, violence and falls, and specific kinds of cancer. What's more confusing, and so what we'll focus for the rest of the talk on, is the effects of limited alcohol consumption. What is alcohol doing at levels that are below recommended limits? And I'll say that basically all of these are a question mark. And we'll talk about these now. Now, I'm going to present, to go forward, two sets of guidelines. First, the 2020 dietary guidelines for Americans. So these were the guidelines up until just a few weeks ago. Let me read these because I think these were very effective. So adults of legal drinking age can choose not to drink, right? Alcohol is not a necessary macronutrient. Or to drink in moderation by limiting intakes to 2 drinks or less in a day for men, 1 drink or less in a day for women on days when alcohol consumed. It is not intended as an average. You don't get to store them up. So going forward, we're going to think about 2 drinks or less in a day for a man, or 1 drink or less in a day for a woman as what we consider the recommended limits. So we'll use that value going forward. I think that was the recommendation for decades up till a few weeks ago, nearly all of, as you'll see, nearly all of the evidence would suggest that that's a wise cap. The 2025 to 2030 dietary guidelines for Americans seem to have largely left nobody happy, in part because they're not really guidelines. They don't provide any numerical guidance whatsoever. They simply say, quote, consume less alcohol for better overall health. Hard to know what that means. And then they are specific and appropriately about people who should avoid alcohol, so people with contraindications, and we'll come back to these folks at the end. I'm largely going to put these on hold because they don't provide us with actually a lot of guidance, despite the fact that they're guidelines, and continue to think about that 2 for a man or 1 for a day in women as an absolute cap. So to summarize where we are now, ethanol metabolism drives its intake and its effects in that low quantity consumption can be converted from acetaldehyde into acetate, but high quality consumption activates other pathways. And acetaldehyde, that is to say this buildup of this intermediate chemical, can lead to cellular injury and carcinogenesis. Primates have long consumed alcohol in a frequent low quantity pattern. That is to say they're going out every night to do it, but it's always with small amounts of alcohol and by definition with food. And evolution appears, interestingly, to have selected for greater alcohol tolerance in higher primates, including ourselves. Alcohol consumption has overall been declining since 1980, although the biggest decline has been in beer consumption, and spirits seem to be gradually increasing. We see harmful patterns of consumption that are common in younger adults. And even in about a third of drinkers over 65, we still see at least self-reported binge drinking. So it's an important area for us to ask about. And finally, all existing guidelines recommend limiting alcohol consumption. Unfortunately, they're a little bit less specific now in what that means. So now let me talk about randomized trials. And I want to start by just making sure we're all on the same page, because these trials use different amounts of alcohol, and so it's important to understand what we mean by a drink. So these are some previous USDA recommendations. They change over time, and but they're all going to stay about the same, which is to say that a single drink represents either 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of spirits. And they all represent somewhere in the range of about 12 to 15 grams of alcohol. So that's the number to remember, 12 to 15 grams, because that's a single drink. I mean, as you can see, they differ in calories from about 100 to about 150, depending on how much carbohydrate they have in them, in the beverage with them. Okay, so let's start with this. So alcohol intake increases ApoA1, which is the main apolipoprotein of HDL cholesterol. So this is the most consistent metabolic effect of alcohol consumed within recommended limits. This was a meta-analysis of 16 randomized trials, which basically show, and just to orient you, these, as we go down, represent higher doses of alcohol. So this is the lowest dose used, and this is the highest dose used. And so if there's a dose response, we would expect it to, let me go backward, to flail out to the right if it's increasing, or to the left if it's decreasing. And so you can see that as alcohol consumption goes up, HDL cholesterol levels increase, and they increase more. This is, again, the most consistent effect of alcohol consumption that we have. So we would expect alcohol to increase HDL cholesterol. Whether it, we can talk a little bit more about what that actually potentially means from a health standpoint, but it is quite consistent. Now, in terms of other lipids, I and many of you may have been taught that alcohol consumption also increases triglycerides, which are another type of fat in the blood, but an unhealthy form. That appears to be true, but with a big caveat. So you can see here that if we go again, this slide is the same as the last. If we look at the difference between the alcohol period and the control period in these randomized trials, we really don't see any consistent effect on triglycerides until the very highest doses. So even not quite the highest doses, we see no effect. And that these last two studies, which use the highest doses, it's finally where we begin to see an effect. So when we do a pooled analysis of this, we see a significant increase only above 60 grams, which would represent about 4 drinks per day. Okay, right, 4 to 5 drinks per day. So when we think about like that number of binge drinking, which was 4 to 5 drinks per day, this fits with that. No clear effect of alcohol and triglycerides with limited consumption, but an increase with binge drinking. Now, interestingly, and I think while those effects may be better known, this is probably not as well known, alcohol consumption with meals lowers blood sugar. So this is a meta-analysis similarly designed of trials in non-diabetic adults. Now, in these trials, these are arranged alphabetically, not by dose. So that differs a little bit, but otherwise, the idea looks the same. If something sways to the right, that would represent an increase with alcohol, and to the left of the line would represent a decrease. So we can see here that across a series of trials, alcohol consumption significantly decreases fasting insulin levels. Fasting insulin is a marker of insulin resistance in adults. So this suggests that alcohol consumption makes humans more sensitive to the insulin that they make. That's a plus. And hemoglobin A1C is a summary marker of blood sugar over the preceding 3 months or so. And in all 3 studies that have looked at this, these were all conducted in the Netherlands, alcohol consumption significantly lowered hemoglobin A1C when provided with meals. So in non-diabetics, alcohol consumption lowers blood sugar, which we would expect to lower their risk of going on to diabetes. Now, at the same time, alcohol consumption increases levels of sex steroid hormones. This is a trial that was conducted at the U.S. Department of Agriculture, of all things, amongst 51 postmenopausal women. And it compares 0, 1, and 2 drinks per day in women. And you can see in the blue bars is DHEAS, that's an androgen, excuse me, and estrone sulfate in orange, that's an estrogen. And alcohol consumption in a dose response manner significantly increases both of those. So this provides evidence that alcohol consumption increases sex steroid hormone levels. We'll come back to that again. And then alcohol consumption also, and now we're back to that same design of our first studies, lowers levels of fibrinogen. In every trial that this has been studied, alcohol consumption lowered fibrinogen levels with an overall net significant effect. And again, a sort of dose-response effect, such that the higher the dose, the greater the effect. Now, everything I just showed you were generally short-term trials. They were anywhere from a few weeks to a few months. I'm now going to present some data from a longer trial. This was a 1-year-long trial. This took 115 patients who had diabetes and had recently suffered a heart attack, myocardial infarction, and then randomized them to either drink red wine every day or to avoid drinking wine altogether. And we can see over the course of 12 months that the red wine is the circles and the squares are the control, that red wine significantly lowers levels of C-reactive protein. C-reactive protein is a marker of inflammation, and significantly lower levels of IL-6, interleukin-6, another inflammatory marker. So here we can see that red wine consumption, at least in this subset of people, lowered inflammation levels over time. It had other effects in this same trial. So it lowered fasting insulin levels. That's exactly what we saw before. Even though this is now in people with diabetes, and what you saw before were people without diabetes. It lowers HOMA-IR. HOMA-IR is a marker of insulin resistance that uses fasting insulin, so those go together. And it raised levels of HDL cholesterol, exactly as we would have expected. So we see these same metabolic effects in this longer trial as well. Interestingly, it also improved left ventricular or cardiac function. So it improved the ability of the heart to squeeze. So just to orient you, again, the circles are red wine. And so we can see that on this myocardial performance index, and on this index, a lower number is better. That alcohol consumption led to a decrease or an improvement in this myocardial performance index. And at 12 months at least, it led to a slight increase in left ventricular ejection fraction, how much the heart squeezed with each beat. So perhaps somewhat surprisingly, that lower degree of inflammation and the improvements in the metabolic effects were also accompanied by an improvement in cardiac function. That was a 1-year study. Now here's the only 2-year study ever done. This is a randomized trial, again in people with diabetes, this time in Israel. And we can see, just to orient you, that water, the water period are the black diamonds, excuse me. White wine are the squares, and red wine are the triangles. And so we can see HDL cholesterol increased with red wine, as was ApoA1, which we would expect. Interestingly, fasting plasma glucose significantly drops with the white wine. And in both cases, it's not clear why these two wines differed, but the other wine had an intermediate effect. Now, all of those are effects on metabolic parameters. This is the only trial that's been done that looks at something we might consider a clinical parameter. This was a randomized trial amongst people with paroxysmal atrial fibrillation. So that is to say atrial fibrillation that's occurring intermittently. They were on average consuming moderately heavily. So you can see the average intake beforehand was above recommended limits. It was about, by self-report, about 17 drinks per week. And randomized individuals to a control intervention, which was basically some education, or to stop drinking alcohol. And over time, their likelihood of going back into atrial fibrillation, if they weren't in it to start, was lower in the people who were asked to be abstinent than in the controls who were not. So here we see, just to be clear, that alcohol consumption seems to increase the risk of atrial fibrillation. Why might this be? This is a trial that was conducted in the electrophysiology laboratory at the University of California at San Francisco, in which alcohol was literally infused while people were undergoing a cardiac procedure. And interestingly, when alcohol was infused, there was a decrease in the pulmonary vein atrial effective refractory period, which is to say that there was a period of time in which the pulmonary vein, an important source for atrial fibrillation, was a refractory from going into AFib, was shortened. So it increased the likelihood that that somebody might go into AFib. So these two together sort of tell us the same story. So to summarize what we know so far, from gold standard randomized trials, alcohol consumption raises ApoA1, it raises HDL cholesterol, and although I didn't show you this, it raises the likelihood that cells will, the activity of HDL, which is cholesterol efflux. It improves insulin sensitivity, as we showed, and it also improves adiponectin, another marker of insulin sensitivity. Again, I didn't show. It raises estrone and DHEA sulfate, so it raises hormone levels, decreases fibrinogen. Fibrinogen is a clotting factor, and reduces pulmonary vein atrial effective refractory periods. So what might that do if all of those things are true? Well, we might get a lower risk of heart attacks because we have higher HDL and we have lower insulin sensitivity. We probably get a lower risk of diabetes from what we saw with the blood sugar levels. But we might get a higher risk of breast cancer because, right, we're raising levels of hormones that breast cancer feeds on. We might have a lower risk of clotting, but a higher risk of bleeding because we're decreasing a clotting factor. And we might have a higher risk of atrial fibrillation because we're making the heart more, we're giving the heart more time to go into atrial fibrillation with every beat. So let's see how all that plays out. So now I'm going to summarize a lot of data from which are the effects of limited drinking in epidemiological studies. This could easily take a few hours by itself, but let me summarize what I think are the salient effects. So first of all, although alcohol consumption at these limited doses does not reliably increase risk of cirrhosis by itself in population studies, it does seem to in people who have other liver risk factors. So this is a study specifically of people with hepatitis C, but you can see similar data, for example, for people with hepatitis B, that as their alcohol consumption goes up, again, 50 grams, excuse me, it's going to be approximately 4 drinks, maybe 3, right? That as alcohol consumption goes up, the time it takes to go into cirrhosis for these people goes down. And that's true even for this intermediate group, which is drinking levels of alcohol consumption that, while not always healthy, are below what we might have expected to cause cirrhosis. So again, put differently, at least in people who have other risk factors for liver disease and therefore may not be metabolizing alcohol perfectly, the more that they drink, the faster that they may go into cirrhosis. Now, we've heard a lot about alcohol and risk of cancer this year, again, because of the Surgeon General. This is perhaps the largest single study looking at that. So this is the Million Women study. This is literally a study of about 1 million women who are recruited from mammography clinics in the UK. So let me orient you here. The blue line is cancer overall. And you can see that relative to the referent group, which was 1 to 2 drinks per week, so well within recommended limits, it was actually a slightly higher risk in women who didn't drink at all. Not much change for women who drank 3 to 6 drinks per week, again within recommended limits. But as we go above that, we clearly see a dose-response association. So with more drinking, there was higher risk. I should note that the absolute risk, right, is a hazard ratio of 1.1. Okay, so it's a relatively small increase in risk, about 10% higher. For cancers, for example, we would on the increase in risk we might expect would be somewhere between 2 to even 20-fold for lung cancer. For esophageal cancer, which is quite rare, again, we see this sort of higher risk in people who didn't drink at all for some reason, but a similar dose-response association, which is really magnified in the highest risk people. And then lastly, breast cancer, which is really what I want to draw your attention most to. It's a simple dose-response association. So the more that a woman drank, the higher her risk. The risk is very low for these small amounts of drinking, but it is a dose response. The more that a woman drank, the higher her risk of breast cancer. Now, what's driving that? So this is a meta-analysis of a much larger number of studies that separated studies by whether or not the breast cancer type responded to estrogen or did not. And the responding ones, the ER positive ones, so these are estrogen receptor positive, are the dark circles. And we can see a positive net dose response association. That's this. So as the more that somebody drank, the higher the risk of getting breast cancer that responded to estrogen. In contrast, for ER negative cancer, so these are breast cancers that do not respond to estrogen, there's not a significant increase. Okay. So we're seeing a difference between whether or not the cancer responded to estrogen or not. For colon cancer, here's a pooled study of 8 separate epidemiological studies. Women are in blue, men are in gray, and we can see no clear association within recommended limits, but we see this higher risk above recommended limits. So colorectal cancer increasing in people drinking above recommended limits. Let's summarize all of that. This is a large study of, as you can see, nearly 90,000 women, 50,000 men, followed for long periods of time as part of the Nurses' Health Study and Health Professionals Follow-Up Study. And I want to spend just a moment on this because it really tells us a lot of information. So we'll start with women here in total cancer. So for amongst non-smoking women, we do not see any clear association. The limit for women drinking is up to 1 drink a day, so that's up to this line, up to this point, excuse me. But even above that, we do not see any clear association. Amongst smokers, risk is already increased. As you can see, it's about double overall. But with greater drinking, we do see a higher risk amongst the smokers. Whether that's because of a synergy between the alcohol and the smoking, or simply because drinking tends to encourage smokers to smoke more, is still uncertain, but we do clearly see that more drinking is going to lead to more cancer amongst smokers. If we focus only on so-called alcohol-related cancer, so things like breast cancer, we do again see that dose-response association, right? So with higher drinking, we begin to see higher amounts, but the overall amount is, the overall risk is much lower amongst the non-smokers than the smokers. That story is more or less similar in men. You can see that for total cancer, there's really no association of alcohol consumption with risk amongst non-smoking men, but there is a trend upward in smoking men, and that's more obvious for alcohol-related cancers. Let's talk about other diseases. So here's the story for stroke. For ischemic stroke, that's to say for strokes caused by blood clots, we see a small decrease in risk. It's not very substantial with light drinking. And then we see by the time we get to above recommended limits, so that's going to be around here, we're already on the upslope. So high amounts of alcohol consumption increase ischemic stroke risk, but small amounts don't seem to. For hemorrhagic stroke, for bleeding strokes, we do not get the same shape of an effect. With higher drinking, higher risk, right? So again, similar, maybe similar to what we might have expected. What about acute risk of atrial fibrillation? So this is a study in which 56 adults who had paroxysmal atrial fibrillation were followed, where their alcohol consumption was actually monitored in real time with an alcohol measurement device. And we can see that if somebody has alcohol, that approximately doubles their risk of going into atrial fibrillation for the next 4 hours and even for probably the next 8 hours. Now, it's true that there's a dose response. The more that they drank, the higher these risks, right? It's about 3-fold higher if they drank 2 or more drinks. But even with 1 drink, it about doubled their risk of atrial fibrillation. So for people always predisposed to atrial fibrillation, even a single drink seems to increase the risk. What about cardiovascular disease? So this is overall cardiovascular disease driven largely by heart attacks. Well, this is where we get what's been sometimes called the J shape. So this was a large study of, in this case, about 40,000 cases of cardiovascular disease, total of about 600,000 individuals. And we could see the so-called J shape. So that as alcohol consumption went down, went up, risk went down, but only until about 100 grams per week. So this is about a drink per day. And then at above a drink per day, it starts going up. It's still lower at about 150, but it's back to baseline a little over 200. So that the bottom is about 1 drink per day. Now, it's important to keep in mind that our drinking pattern matters for that. That's just average alcohol consumption, but how we drink it matters a lot. Turns out that as frequency goes up, as to say, as the greater number of days per week that someone drinks, the risk of myocardial infarction at least goes down, of heart attacks goes down, but there's no benefit of drinking more on those days. right? So it's not how much people drink on those days. Even for people who are drinking less than a full drink per day on those days, we still see that as the gray bars, we still see this lower risk drinking 3 to 4 or 5 to 7 days per week. We see that that was in men. We see this a similar association in women. You can focus on these light purple points. So 1 to 2 days per week, we don't see any lower risk, but we do see lower risk with both 3 to 4 and 5 to 7 days of drinking per week. Does the beverage type matter? Is that restricted to red wine, for example? Doesn't seem to be. It was a meta-analysis that was already done now 20 years ago. We had all of this data available, and you can see that that lower risk is essentially the same for wine, for beer, and for spirits. What about for diabetes? We see almost an identical picture. So as alcohol consumption in days per week goes up, risk of diabetes goes down. But if we ask the number of drinks per day, we don't see it, right? So it does. So, and in fact, for people who are drinking regularly, it's the opposite. The biggest benefit is in people who are drinking less than a drink per day, but doing it on multiple days per week. Here's the same question about diabetes. This is in about 300,000 drinkers from the UK Biobank, but here we're looking at a different element of drinking pattern, namely what was the alcohol consumed with meals. So it's looking at average drinking with or without meals. This set of people in the triangles drank their alcohol without meals. So they drank it at a bar, wherever, by itself. And you can see there's no clear association of alcohol consumption with diabetes. But amongst people who reliably drank alcohol with meals, the more that they drank, the lower their risk of diabetes. So that another element of drinking pattern that matters seems to be whether or not people drink with meals. That should sound familiar. Now, what about mortality? So I showed you this graph before. This was of cardiovascular disease, about 40,000 events, 600,000 people, about a similar number of deaths. And we don't see that same J shape, right? And so this was one of the first studies that led to this idea that all drinking must be bad. Because we don't see this J shape. It looks like alcohol is neutral up to about a drink per day, but then even at 150 seems to start increasing risk, albeit very modestly, and then more strongly so above 2 drinks per day. And so this raised a lot of concern that we might be missing a harmful effect of even low dose drinking, even if very light drinking up to a drink a day seems still to be safe. However, that picture is a little bit misleading as well based on what we just saw. So here's the same image you just saw, but now this is taking the same data and breaking it out in studies that had drinking pattern available. And you can see in red is the effect of more drinking for people who drink only on weekends, essentially. This is 2 or fewer days per week. So if you only drink on weekends, the more that you drink in total, the higher your risk, right? So if you're only going to drink on weekends, drink a very small amount when you do, right? Like a drink a day. In contrast, for people who are spacing it out over the week, we can see that same J shape again. And now we see lower risk at about 100 grams per day, similar to what we saw for cardiovascular disease, and it's still lower even for 200 grams per week, excuse me. So what we're seeing here is that same drinking pattern effect. So to summarize, we see a higher risk of cirrhosis in people, especially who have viral hepatitis or other liver risk factors. We see a higher risk of breast cancer in a dose-dependent manner, but especially for ER positive, for these estrogen receptor positive cancers. We do see a higher risk of colon and indeed other cancers, like esophageal, at above recommended limits. We see a higher acute risk of atrial fibrillation. We saw a higher risk of hemorrhagic stroke. Generally lower risk of coronary heart disease and diabetes, though, but drinking pattern mattered a lot there, right? Lower risk was tied to low quantity consumption and with meals, but beverage type didn't seem to matter very much, although that I will acknowledge is, remains an area of ongoing discussion. Now, I want to remind you that based on what we saw from the randomized trials of biomarkers, that's exactly what we expected. So these biomarkers gave us really important insight into what to expect from the epidemiology, because in this case, they predicted all of these effects. Now, that sounds great, but what don't we have? So I want to sort of provide a contrast. This was now a year ago, and I think we're going to have similar data, a similar announcement on this from the US News shortly. The Mediterranean diet last year was the best diet once again for the 8th year in a row. Now, many of you have the belief, quite rightfully, that a Mediterranean diet is healthy and maybe the most healthy. Why do you believe that? Well, a big reason why you believe it is because there's actually been a randomized trial to test the Mediterranean diet. This is the Mediterranean diet as was tested in a 5-year-long randomized trial of over 7,000 adults in Spain. They were randomized to have a Mediterranean diet or a healthy but a low-fat diet. So it was not being compared to an American diet. It was being compared to a reasonably healthy low-fat diet in Spain. And I'll draw your attention here. Compared to the control diet, this is risk of heart disease over time, the Mediterranean diet, and there were 2 different sort of arms of it, both led to substantially lower risk. So the reason, quite rightfully, that the Mediterranean diet is viewed as the most healthy is because it has been tested in a gold standard randomized trial and shown to lower risk. I have not shown you that for alcohol. I haven't shown it to you because we don't have it, or maybe I'll amend that to say we don't have it yet. So the good news is that the group that did the trial that I just showed you, called PREDIMED, is in the process of doing a 4-year randomized trial amongst 10,000 Spaniards. They have just about completed recruitment, so they are going to successfully get about 10,000 people. And they're being randomized for over 4 years to either stop drinking altogether or to cut back their drinking to within recommended limits. Most of these folks were drinking at or above recommended limits, so it's a little bit of a funny design. But if we are lucky enough to get together again in 5 years, hopefully we'll have data just like what we saw for PREDIMED to inform our discussions. So to summarize that, alcohol consumption remains a topic of enormous controversy because no long-term randomized trial has ever been conducted. But we've seen that trials of up to 2 years can be conducted, and we've seen long-term randomized trials of diet. So it's been a real problem for us that there hasn't been a long-term trial to date, but one may be in sight. In the absence of a trial, I really want to focus us on places where the physiological effects from randomized trials match the observational data. And I want to emphasize that education remains absolutely essential about what really limited alcohol consumption is doing. Just to highlight that point, this is data from the EU. It was a survey of about 20,000 drinkers. And they were just asked, what do you think alcohol does? And about 70% said alcohol causes heart disease. As we saw, that's actually a complicated story. 90% said alcohol causes liver disease, and certainly at high doses or in people with risk factors, that's true. Only 15% could identify breast cancer as a risk of drinking, even though that's probably the single most consistent effect that we saw in terms of a dose response. So we really need to get this story out about what the correct limits are and what it does. So to sum up, for clinicians thinking about this, there's no good reason to be asking people to drink. There's lots of interventions that we can encourage that prevent multiple diseases. When we talk to people about drinking, we should screen with at least 3 questions, like using the Audit C questionnaire, which means we ask about how often they drink, how much they drink on those days. We saw a lot of data on this, and how often they binge drink, and we saw data on that. I'd probably add a question about drinking with meals as well to that. But that's not part of the Audit C. There's no reason to recommend people who have never drank alcohol start doing so. But if adults drink and do so responsibly, then we would recommend that they drink alcohol like other primates, which is to say, drink small amounts. You can do it multiple days per week, but only small amounts at a time and only with food, exactly the way that our ancestors have. And this provides strong support for those limits established by the 2020 Dietary Guidelines for Americans. I want to emphasize that alcohol consumption remains most likely to harm younger individuals. We saw that high level of binge drinking in that group. And premenopausal women for whom that risk of estrogen receptor positive breast cancer remains an important concern. And so I'll stop here. Our best advice remains simple. For those with contraindications, consume no alcohol in bold. And for those without contraindications, consume no more than 1 for a woman or 2 for a man drinks on any given day ever. And with that, I'll leave us with the last dietary guidelines for Americans and take questions in my 1 minute remaining.
All righty. Thank you so much, Ken. Okay, there I am. All right. Yeah, we are running out of time. However, I do want to try to get in one question. So thank you so much for sort of um, putting some sense to all the mountain of data that's out there. I know it's not straightforward, but this is really helpful. So I wanted to ask a question because there are a few in there regarding genetics. Sort of how does that, there's a question, are there twin studies to sort of, give us a little bit more information? I mean, we think about personalized medicine these days, so like how does genetics play a role? Is it, yeah, I'll leave it at that.
Yeah, so it's a good question. And in other circumstances, and I'll put in a plug that we're the Harvard-wide Grand Rounds on Thursday, which is open to the public, will be on the same topic. So encourage folks to join in on that. We'll talk a little bit more about the genetics. Genetics plays a role in a couple of different places. So first, as I mentioned briefly, about a third of East Asians will have a genetic predisposition to metabolize acetaldehyde poorly, leading to a sensation of flushing when people drink. It turns out that there's a separate variant in the ADH, in the first enzyme, that speeds it up, that also leads to more flushing. And that's most common in Jews, as it turns out, but also in people of African ancestry. For those groups, which is to say, if you're somebody who, when you drink, you don't feel well because you have this buildup of acetaldehyde, you shouldn't drink, right? Because that's a signal that you're making more of this harmful chemical. And so that's the simplest response, that for people whose metabolism is such that they can't convert alcohol safely to acetate, to vinegar, don't push it. There's no reason to. It's more complicated for other groups, but that's a really easy one for almost everybody to remember. We'll talk a little bit on Thursday about trying to use the genetics to inform what we know about alcohol. But I'll suffice it to say that I don't think we're there yet for that.
Okay. So folks can stay tuned and maybe join that other talk for a little bit more information. And because you mentioned the vinegar, I just have to ask this other question because it did come up in one of the questions is, so are there any studies head to head, vinegar and alcohol? Why we do know actually that vinegar, we think we know that it has a lot of good health effects. So why not just drink vinegar? I saw in the beginning, you sort of, goes from acetaldehyde and eventually to the acetate, the vinegar. So,
Right.
uh, yeah.
So that's a great question. Boy, what a good idea. So there are no head-to-head studies. There are randomized trials, as you note, of vinegar, looking at things like glucose metabolism that are at least suggestive that some of the benefit that we see of alcohol on blood sugar levels is because it's being turned into vinegar in the body. There have not been any randomized trials comparing alcohol to vinegar on things like blood sugar or anything else, to my knowledge. So that's a really good idea, and thank you for for giving me something to start working on. But But there are other effects of alcohol that are probably very different than vinegar, right? So, for example, we don't have any evidence that vinegar has the same kinds of effects on blood clotting that and lowering fibrinogen that alcohol does. So it may very well be that vinegar is a really interesting choice for people who want to use that, but I don't think we're going to be able to compare the metabolic effects kind of one to one.
That makes me think about, what about the rest of your diet? What else are you eating that may impact, sort of like you are what you drink, within you are what you eat, and how does that all come together? So, anyways, I know we've run out of time. Thank you so much, Ken, for enlightening us. And I'm just going to close out by sharing my screen again. I do have a couple announcements left for the Osher Center. So let me just do this very briefly. Okay. Sorry, my slides are not advancing. Okay, let me try this again. Okay, so this is announcement for our upcoming grand rounds. So next month, March 3rd, we have Dr. Robert Edwards that's going to tell us about Reiki. So this is Reiki, Fakie, and mindfulness, a randomized controlled trial. Um, and then in April, we have Dr. Deidre Tobias, who's going to be giving the second talk within this You Are What You Drink series, and that's on sugar sweetened beverages. And you can register with the QR code here. And then I wanted just to announce the 2026 Science of Tai Chi and Qigong as Whole Person Health Conference. You all have hopefully heard about this by now. Registration is open. It's going to be April 30th to May 1st here in Boston, just at the Martin Center, and really looking at the latest scientific research on Tai Chi, and really sort of going deep into the physiology. And this is going to be relevant for folks that are studying mind-body therapies, other movement-based mind-body therapies like yoga. I think it's going to be a really fantastic event that I hope you all will attend. And then finally, all the work that we do at the Osher Center, of course, needs support. And so if you are so inclined and interested, you can feel free to make a donation to Osher Center to support our many programs. And with that, I'm gonna end today's grand rounds. Thank you again to Dr. Ken Mukamal for telling us about alcohol, and everyone have a wonderful day. Stay warm out there. Thanks so much.